Okay, it is day 17 of my hypersomnia video diary. Um, as I mentioned in yesterday's video, today I would be talking about information related to clinical trials, and then also go through some of the most popular emerging medicines for hypersomnia. And I say most popular because these are the ones that I can actually find articles on. There's several, but I'll go through the most popular today, and I can always come back and touch on the other ones. Okay, so firstly, there's a really great website for all neurological diseases and conditions, and maybe even other biological and medical conditions as well. But that is clinicaltrials.gov. Once you get there, you can just search, put in your disorder or something like it, and search. And what's really cool about the site is it shows you the results. It not only shows you upcoming studies, it shows you which ones are still ongoing, which ones are recruiting for the upcoming, and then also which ones have closed, and you can also take a look at what the results of that study were, which is really nice. So just for example, I searched hypersomnia, and for me, a couple popped up that I thought maybe would be interesting. One of them was kind of weird. So the first one was a study in safety, a study of safety and efficiency of BTD-001 in the treatment of narcolepsy, for idiopathic hypersomnia and narcolepsy type 2. Immediately I was like, wow, that's me. This sounds really cool. They had a location in California and a couple other around the country. And the only issue is that when I looked at it, the inclusion criteria said that you could not be currently undergoing any pharmacological treatment for the condition. So that got me to thinking. I had a look at the other ones, and a few of the other ones say the same thing. And I get it; they're trying to you can't stop taking maybe your current medication, or they want like a clean slate to test upon. But they need you can't take your current medication if you're going to be taking an investigation one, and that probably excludes me from a lot of these because I'm assuming they're testing out new drugs and new chemicals. So I'd be I'm going to keep checking back, but I'd be kind of eager to see if they have any for ongoing patients. So there's another one. Let's see here. Rare disease patient registry and natural history study, a coordination of rare diseases at Sanford. So that's another cool website too. Their little acronym is CORDS. This is a Sanford-based school, and you can go and register there for sleep studies and get information and things like that. So that one's a possibility. Although I tried to register on their website, and it just kept telling me that I had not all the required fields filled out, but I did. So I'll try it back in a day or something. The one that I said was a little bit scary. Says transcranial direct current stimulation therapy for central hypersomnia without cataplexy, which I would also fall into that category. I don't want to be electroshock therapy, although I think it's interesting, and if something like that could fix it, I'd really have to think about that. But it seems so dangerous, you're messing with electricity and things, but who knows? So those are really the gist of what's available for hypersomnia now. There's more than 30 studies all in all that, a lot of them had closed, and some were still recruiting, or some were just in the ending phases and just kind of posting updates, which is another cool thing. You can actually check out the updates that are happening there too, from time to time. So the next thing I'll go into is you can Google hypersomnia investigational drug list, and it'll come up on Wikipedia. And so hypersomnia, they've broken it down to four known categories of drugs that they're testing, and then one is unidentified, which I'm not really sure what they're saying is happening there. But it's an unidentified mechanism of action. They don't know what it's actually. They know that it's affecting something in some way, but its total makeup is still unknown. The ones that I thought were interesting are the aminogenics. I can't say that right now, but so those are dopamine and norepinephrine produce and serotonin producing chemicals. So I'll go through those. There's also a big movement on the GABA receptor inhibitors, and then they note here GHB receptor. GHB receptors are noted as well, and I mentioned this chemical before. It was like Xyrem. It's sodium oxybate. That chemical had made me very tired before, because it's primarily trying to get you, to have a more restful, restorative sleep. But it seems like they're testing different versions of it now. One a mixed salt solution, one a controlled release. So they're trying a couple things right there, because the GHB also works with the GABA receptors, which I'm actually going to get into today. I haven't brought that up yet. And then our old friend histamine, or the H3 receptor, they're noted there. And again, lastly, the others was an undefined category. So I've already talked a lot about the dopamine and norepinephrine issues. So today I thought it would be cool to go into the one of the other ones that's kind of like, I'd say, the one of the last ones outside of the undefined category, really to test and explore. So you have GABA-A receptors in your brain, and the sleep-inducing substance in patients' cerebral spinal fluid. Those patients with narcolepsy or hypersomnia have increased GABA receptors, which are they inhibit the central nervous system, and your GABA receptors become active when you're supposed to go to sleep and things like that. So what they're finding is not a and one other note: the GABA receptors are historically they were identified, and most of the science with them has been through benzodiazepines, things like Valium and sedatives. They bond to the GABA receptors like very well, and they induce sleep a lot more. So they were looking at scientists were looking at chemicals that would kind of do the opposite of that, and they found one that makes it so a benzodiazepine can't really bond to those GABA receptors. Instead, it's a different chemical, and that chemical doesn't allow it reduces quickly any drowsiness or sleepiness caused by the benzodiazepines. That chemical still being tested now for hypersomnia. Originally, it was only used as a stimulant for respiratory, and in actually trying to counteract the effect of someone overdosed on a Valium or things like that. So it's a selective benzodiazepine receptor antagonist. Currently, it's only available in injection and in intranasal, and what I was reading about it is actually the next one. So it's a little bit tricky about how you have to take it there. They're working on and testing out the pill-based forms of that now. So that's interesting though, because instead of giving your body a bunch of chemicals, a bunch of the neurotransmitters used to promote wakefulness and things like that, it doesn't give you those chemicals. It just prohibits your sleepy chemicals from really being able to be so active. And let's see, interesting too, in a laboratory test, the size of the effect the size of the effect on GABA receptor function is more than twice as large in hypersleepy patients on average than in control samples. So hypersomnia people are thought to be greatly affected by the GABA receptor, over affected almost. This Dr. Rai goes on to note, in some of the severely affected patients, in some of the more severely affected patients, we estimate the magnitude of the GABA enhancing effect as nearly equivalent to that expected for someone receiving sedation in outpatient colonoscopy. This is the level of impaired consciousness that many subjects had to combat on almost a daily basis in order to live their usual lives. So that first one is flumazenil, and again, that's working at the GABA receptors. The second one I'm going to mention too also is working at the GABA receptors, and that is phenylene tetrazoles, or BTD-001. This drug, it was formerly used as a circulatory and respiratory stimulant, and it was developed for cough syrups back in the early 1900s. They're finding now that this chemical is able to bond to their GABA receptors, and it's thought to either block the GABA-A receptor channels or as a non-competitive antagonist for GABA receptors. But the issue with this drug is it's been known to cause convulsions, and dosage is currently given sublingually under the tongue and in conjunction with intravenous. So you have to, for this chemical to work right, what they're finding right now is that you have to have an intravenous injection of it, and then it has to slowly be administered, into the rest of your body. Lastly, we'll go over to our old friend histamine there. So there's two for, actually just one here. Yeah. One that kind of stood out for histamine, and it wasn't so impressive. So recent, as I mentioned before, recent evidence suggests that activating neurons that release histamine in the brain, can possibly treat narcolepsy. So they've developed this drug called, pitolisant, and it's been shown to activate histamine neurons in the brain. It was the first H3 inverse angst to be tested in humans or introduced for clinical use. It's also known as tiprolisant, and sold under the brand name Wakix, which sounds kind of weird. It selectively inverses the uptake of the histamine H3 receptor, and it was improved for the treatment of narcolepsy in 2016. It's currently in phase 3 of clinical trials for being tested for hypersomnia. Reports coming back from people testing it say the benefits are similar to modafinil or Provigil. But trials are still underway. But lastly, they're suggesting that this may be beneficial to people with idiopathic hypersomnia and narcolepsy stage 2, but it most likely will have to be used in conjunction with medicine you're already taking, or something else that you may have to work into your regimen there. And the problem with that is who wants to have to take two pills, or who wants to have to take a pill and get a shot, or has to take a medicine through the mouth and then have to get also I don't know, or also take a pill. It's kind of like, what's the point if it only kind of works and then it still has to be used with something else? And that's just my opinion. And again, as more tests come out, it may be it may prove to be a better chemical than I'm giving credit here for. So those are the only ones that I'm going to go into today. I still haven't gotten to Vyvanase, which I will definitely before this whole 30 days is out. I know this one was maybe a little bit blah blah today in terms of me just reading off chemical info and stuff, but really the thing to take from it is, finally they're now that idiopathic hypersomnia is fully in its own, it's its own disease now, so to speak, and moved out from narcolepsy's shadow. It's getting a lot more testing, and more medications are at least being tested and looked at. So the hope for the future is always promising, and all in all, you can't lose hope. So, all right, well, I will see you on day 18, which not sure what I'm going to get into yet, but it'll be more entertaining than today, hopefully. Thanks.